All right. Thank you. Thank you, everyone. I see people are joining. Um, Thank you so much for making time to join today's session, which is part of the 12 sessions on African climate resilient and sustainable health systems and facilities. And we really value that you took time with us to learn from some of the leaders that we have, great leaders that we have on the continent, and also to gain some of the practical skills in terms of really the roles that all of us and our different stakeholders can play. So today's session is looking at the health adaptation process, where we're really looking into key actors, activities, and partnerships. So we really look forward to the conversation. So just a reminder, we have um, we have interpretation on the call. So we have simultaneous English, French, and Portuguese interpretation. So for you to access the interpretation, we you click the interpretation button, which is on the bottom of the screen. If you are joining using a laptop, then you choose your preferred language. So in today's session, we have speakers in French as well. So we encourage all to use to choose your preferred language. Um, that you to listen into throughout the session. Then if you're joining from a mobile phone, click on the three dots that you see on the bottom of the screen. That should show you an option to choose interpretation as well. We encourage you to use the question and answer part to send through any questions that you may have for the session. So as I mentioned, this is part of a uh, 12 session course that interconnected and that we hope will really help you in your different roles to be able to contribute towards a resilient health system. So the first session introduced us to climate resilience in health system. Then it was followed by a session on methods for assessing vulnerability and adaptation. Then the third session was on vulnerability, capacity assessment for facilities and communities. In case you missed these three sessions, we encourage you to check the YouTube page for the Global Consortium on Climate and Health Education, where you can see recordings of the previous sessions. So today's session will focus on the health adaptation process, as mentioned, really looking into key actors, activities, and partnerships. Then some of the upcoming sessions to look out for on the 3rd of September, we have health early warning systems and surveillance. Then if the session in September on the 10th will be on lowering the carbon footprint of health systems. Then we have another session on sustainable facility operations, looking at energy, water, and waste. Then measuring and monitoring, evaluating health systems. You can find more information about the rest of the sessions that are coming up on the website, and we encourage everyone to invite your colleagues, your partner organizations, and other institutions you work with, and other stakeholders you work with, to join this conversation. And as you will see from today's discussion, the importance of multi-stakeholder collaboration. So, just a reminder, and to those who joined previous sessions, and also information to those joining who's joined us today, that the assessment for certificates is through attendance of the live Zoom sessions. So when you register for a Zoom session with the Zoom email, we encourage you to use the same email that you use for registration to join the sessions. That way, you'll be automatically registered. Your attendance will be automatically registered when you attend the session and that. And certificate will be given to people who attend um, at least 8 sessions and also score more than 70% at the end of the course. So those are the people who attend who attain the certificate of participation. So for those joining the today, for the first time, I encourage you to then attend the rest of the remaining sessions for you to get to the number 8. So it's not too late as well. And always feel free to reach out to the team on global, also the global consortium on climate and health education for more information on that. So this is just explaining what I mentioned earlier around like the importance of using your own link that you registered to attend the session, and only just repeating that only the live Zoom sessions are counted for participation and not YouTube views as well. So it's something to bear in mind for you to be able to get the certificate. And feel free to reach out to the team for more information as well. So there is a WhatsApp group that we encourage you to join. So you get information and updates regarding the course, and also you get resources as well as information on upcoming courses as well. So we really encourage you to scan and join. I'll just give people maybe just a few seconds to scan and join the WhatsApp group as well. Then the link will also be shared in the chat if you don't manage to scan at the moment. So today's session, the main objectives will be really looking at the core steps of the health adaptation system process, looking at risk assessment, priority setting, planning, implementation, financing, and monitoring. Then our speakers will also take us through the various roles and responsibilities of key stakeholders in advancing climate and health adaptation. That will include health planners, clinicians, public health authorities, researchers, civil society actors, and cross-sector decision makers. So I also encourage you to also share this session and also encourage other stakeholders you work with to join this very important course so that you all see some of the important roles that you can play and how we can all collaborate together. Then another objective would be to identify the partnerships and governance structures necessary to develop and implement a climate change and health adaptation strategy, ensuring coordination across sectors and levels of the health system as well. So the governance part of it is quite very important, especially when you're really thinking about sustainability and we're really thinking about more coordinated effort as well. So to take us through the session, we have we're privileged to have Prof. Watanzi Kutania, who's the National Professional Officer for Health and Environment at WHO. Then we also have Dr. Kodu, who's the head of Oral Health Division, Health, Environment, and Climate Change Focal Point with the Ministry of Health and Public Hygiene of Senegal. Then we have Mr. Lolem Lokolile, who's the Deputy Head of Division and Health Pollution Control and Climate Change and Health Unit for the Ministry of Health of Kenya. So for our speakers, I also encourage you before you speak to remind us how we correctly pronounce your name, and I really apologize if I didn't pronounce your name correctly. So our first speaker will be Prof. Wataji Kutani, who I mentioned is a public health and environmental health specialist who is currently serving as the National Professional Officer for Health and Environment at the World Organization Ethiopia Country Office. He has advanced academic qualifications in uh, in environmental health, public health, human ecology, and a specialized intersection on climate change, environment, and health system. He has so many years of experience where he has played leading roles in supporting countries on the continent to strengthen climate resilient and sustainable health systems across Africa. He also has extensive experience in conducting climate change and health vulnerability and adaptation assessments, climate sensitive health risk mapping, and the development and implementation of health national adaptation plans. He has provided technical leadership to support the establishment and strengthening of early warning alert and responsible systems for climate sensitive disease and public health threats in Ethiopia and Mozambique, while also supporting similar initiatives in several other African countries. His work focuses on translating climate and health evidence into policy and practical actions that protect vulnerable populations and strengthen health system resilience. So he's not a new face in the climate space conversation. I think if a lot of you have seen him present on many different topics, so we're really excited to hear him really uh, take us through his presentation for the session. So over to you, Professor Wataji. Thank you.
Oh, okay. Thank you very much. I'm trying to share my presentation. Is it coming now? Okay.
Not yet.
Not yet? Okay, let me try again. I don't know today what is happening. Okay, so let me go here. Share. Share. Can you see it now? Hello?
Yes. Yes.
Okay. Thank you very much for the opportunity also. And then I'm happy to share the experience, also some of the scientific issues based on the WHO and UNFCCC framework on this adaptation. This adaptation include also the vulnerability assessment, but we have done that both for the nation, also on the healthcare facilities. So that part has been covered. Assume that the VA has already done, and then based on the adaptation option identified in the last two sessions, my colleagues presented the last week and the before last week. We are going to develop now the Health National Adaptation Plan. This is the second phase of how the country can plan for the climate change. So this is the outline. I'm going to use it. This is very quickly. I'm not going to repeat because Denash has already presented the objective of this session. So, but I want to make sure when you are looking to against my slide, I've tried to arrange the slide against the three strategic objectives. So to start as an introduction, this has been also said during the opening on the climate change, the climate hazard. For instance, this is the variability on seasonal variability like flood, drought, storms, heat, and then the temperature increase, which is mainly after 3 decades, and also sea level rising. These are the hazard, what we call in climate hazard. So what are the health impacts from this? The malaria, the cholera, and then the malnutrition and the heat stress is all these, the impact on health from the hazard. Then also there is a response. The response for the health sector can be surveillance, WASH, preparedness, and the resilient healthcare facility. So you will see the impact. This is the first line graph is showing 13 years trends of heat stress in South Sudan, which is very critical. And then school closed, children stayed at home. This is what has been happening over the last 13 years in South Sudan. And then you will see also the vector-borne disease. So from this simple conclusion is that climate change is not just about a science. It is about people, health, and the survival. So from the heat stress to the spread of malaria, climate change is a matter of life and death. So it's not only science. So these are the climate pathways. I've already said in summary this, the rise of the temperature, the increase of, so it favors the malaria mosquito breeding. Then the heavy rainfall, you will see the water contamination, which is related also to cholera. And then the drought, the food insecurity, and then we'll have the health impact, the malnutrition. Then the overall message is what climate change and the climate variability is doing that it is a multiplier of the threat already existing health threats. So the vector-borne, the malaria, the waterborne disease, the heat-related stress, and the malnutrition, all this is climate change impact is a multiplier of all the threat already existing. So that is why we need to undertake the vulnerability and then come to the adaptation, developing the adaptation plan. So now you will see we need to be very clear on the terminologies when we are talking about adaptation. We have already said in the first session about climate change definition, which is a long term over at least 30 years. And then also the vulnerability, my colleagues last week and before last week has already dealt with this. We'll have the definition for that. Today, we are going to deal with the adaptation. So adaptation is the process of adjusting human and or natural system to actual or expected climate change and its effect in order to reduce harm and then take advantage of beneficial opportunities. So the resilience is, so why we are developing the HNAP is to ensure the resilience. So the resilience is the capacity of individual, community, ecosystem, and the health system to anticipate, to withstand, and then respond in the recovery while maintaining the essential function, in this case, the essential health service. So these are the very important terminologies. These 5 terminologies very important. Climate change, resilience, adaptation, and the vulnerability. Climate change, vulnerability, and then adaptation, and then the resilience. The whole intent of the adaptation plan is to ensure the resilience because of already what is happening, natural and human, the climate change, and the vulnerability can be an economic, pre-existing disease, and the geographical location, and then all those things. So we need to adapt the human, the ecology, and the local at local scale. Now we are talking about national and then to district level when we are talking about adaptation. So what is the adaptation? What is the basic principle under the adaptation? The first document which I brought is the National Adaptation Plan. This is a document, a guideline from the UNFCCC, United Nations Frame Convention for Climate Change Secretariat, which is based in Bonn. This is the overall sectorial guideline to develop. It can be for agriculture, it can be for health, it can be for water. But this one is the WHO guidance to protect health from climate change through health adaptation planning. This is the document we are using for the health. So we have here, we have here the UNFCCC National Adaptation Plan, Climate Risk Assessment, Adaptation Priority for sectors. If you look at the NAPA of many countries, you will see health is among the top 5 sectors identified for the priority NAPA national adaptation plan development. So the sector integration, the health, the water, the agriculture, both they have their own adaptation plan. So the WHO framework for the HNAP here is based on the risk assessment, which is generated by the vulnerability in the risk assessment. So in that risk assessment, actually the final goal of the vulnerability in the risk assessment is to come up with adaptation actions so that can be translated to the healthy national adaptation. So I'm not going to read why I just brought this definition in a very written long way for you guys to read when you go back and in your free time. So the health adaptation plan here is the health sector's contribution to the NAPA. It is not a standalone. It is a standalone, but it is a part of the national adaptation plan. It focuses on assessing climate-related health risks, identify vulnerable population, develop adaptation measure, and then strengthen the health system to ensure the resilience. So the WHO framework, if you look at the WHO framework, the WHO framework focus on the health specific component of the national adaptation plan, but the NAPA is a sector-wide mid-term and long-term adaptation needs. Agriculture, health, water, all those things. So the intention is to consider the vulnerability and build resilience on the principle of participation, transparency, including gender inclusivity, sensitivity, and also resilience on available science and indigenous knowledge. Indigenous knowledge is also very important. How people are coping when a shock happened due to climate change and the climate variability. So this is the principle for both the WHO and the United Nations framework for climate convention, which is developed by the Secretariat for this convention. So we will have the integrated framework. We have the vulnerability, which is government identify most vulnerable groups, sectors, and the geographical, and then outline the corresponding health impact and the vulnerability. So the VA that is why important. In the NAPA, countries outline strategies to reduce their vulnerability to climate change and increase their resilience against the related risks. Then we have the Health National Adaptation Plan, the health component of the NAPA. So HNAP is the health component of the NAPA. So we will have also mechanism for reporting on this. We call it a national designated contribution. This need to be reported to the UNFCCC. So, for example, in some country in Ethiopia, they consider in the national designated contribution reporting, where they are reporting to the UNFCCC, there is 48 indicators for the NCD. 8 of them was on health for Ethiopia. I think I've seen number of countries like for Rwanda, for Mozambique, for Madagascar. They have an indicators where as part of the NDC. So we are not going to touch this one. Maybe it's going to be covered in another session. I'm going to deal with the HNAP. So these are the 4 processes. This came also from the WHO guidelines and the WHO training, attached training. So we need to align to lay out the groundwork and address the gaps, which is align the HNAP with the NAPA process, take stock of available information, address capacity gap in undertaking HNAP. We need to use, for example, the health sector, they may not have that capacity in undertaking the VA, so that they can use the universities, multi-sectoral, different universities with a different background, bringing on board to undertake the VA so that they can generate the adaptation option, which can be used for the HNAP development. So we need to have the preparatory work as the second process, conduct the health vulnerability, which is already covered in this course, then review the implication of the climate change health-related development goal policy, and then there is a need to develop the national adaptation plan. Then there should be an implementation plan and funding for that. And then there should be a coordination synergy with the other sector, the water, the agriculture, the nutrition part. So as we implemented also, we need to monitor and review the HNAP. It's most of the time, the Health National Adaptation is being developed for 5 years. It has to be regularly updated and then report on the progress of the HNAP as part of the NGC also, because we need to review also every 5 years at least, or 10 years, the vulnerability assessment, and then accordingly, we need to revise the HNAP. So one of the important things in the objective, if you look at the objective, so the stakeholders ecosystem and the engagement. You will see the Ministry of Health as the leader and the coordinator and also implementer in between. We'll have the Ministry of Environment, Water, Agriculture, partners like WHO, World Bank, UNICEF, and then also NGOs. Then we have the community, which is very important for us, the community actions, and then the community participation. We need to have also the universities as the partners. To which country I've used to, those countries have been traveled to support, I always ask the participation of the universities colleagues in the VA as well as in the HNAP. In most of the country, we missed them. But from my experience and my own country in the Mozambique, the university people are very important people in this endeavor. So the Ministry of Finance is also very important. So the rationale is why we need the stakeholders is to ensure the whole of the government process to bring health, environment, water, agriculture, and the finance sector together, because these are the health determinant sector. Health is not disease and the days. Health is a well-being. So without these sectors, we cannot ensure the well-being. So we need to think the healthy people, especially us, we need to make sure the engagement of these sectors. Improve the resource efficiency in the mobilization also, stakeholder engagement, strengthen the evidence-based decision, the university people, the research institute, community ownership and the participation in those actually when we are implementing on the ground. I've seen this from the climate resilient water safety plan. We implemented the community engagement in addressing climate variables to the safety of the water. So increase impact, also sustainability. This ensures the sustainability. In these stakeholders, we need to ask who does and do what in the HNAP process, from development to the up to the evaluation. For example, I just picked the health. Even in health, we have a different sub sections, partners, the health planners, those who are allocating the budget. The public health authority, those who are doing the surveillance and the preparedness, the clinician who are delivering the service and the case management. For example, a clinician who is managing a malaria, when the incidence of malaria increase, he or she need to ask why in that catchment area malaria is increasing. What happened to the climate? Because these are climate-dependent diseases. This is just an example. The temperature, the rainfall, and the relative humidity. So the clinician who is treating malaria there need to understand how climate is impacting the malaria. Then the researcher, the civil society, and the community engagement and other sectors are very important. For example, the health workers, they have to educate the public, enhance monitoring, and then also contribute to the public dialogue, and then do the research. So a person who is treating the malaria, when the incidence increase, he has to do some kind of operational research. Why malaria is increasing now here? Is it the intervention at the community level is not appropriate, or is there a change in the climate? Then I just came to ensure that you guys, when you are going, how we are going to develop. So this step, I've used this one in Ethiopia also when I supported also Botswana last year, and also when we gave a training in Zambia last year, and also this year for the East African with African CDC in Nairobi, we used this step. So when we are developing a costed health national adaptation plan, we need to define the scope and the objective, identify and prioritize adaptation action, through the vulnerability assessment. It's already there. Then break down action into costed component. For example, personnel, equipment training, and workshop, infrastructure upgrade, training of staff, and then improved. If we want to pilot the EWARs, we need to select those, for example, cholera-prone district, malaria-prone, dengue-prone district. So we need to, how many sentinel sites we want to, or we want to open, or are we going to cover the whole country? Then the estimated cost for this activity. Then calculates the total cost based on that. Then we need to identify also the funding source, the domestic, how we are going to integrate to the domestic health budget, then international climate financing, how we are going to look for the development partner support, and then the private sector also. So, for example, how we are going to include the private hospitals, private clinics, to the surveillance system in picking those climate-sensitive diseases by just training them and including in the training, not only for the public healthcare facility, but we need to think also the NGOs, health providers, and also the private sector. So the other important is we need to develop finance strategy. How we are going to integrate to the existing budget, what percentage we are looking from the development partner. So we have to be very clear on that also. So we need to validate also and the review once we develop with engagement of the experts from different partners, but we need to engage also the wider stakeholders in developing the HNAP. So including the stakeholders we have already said, integrate to the national budget. So aligning with the medium-term expenditure framework of the health system. Not only really don't develop HNAP by looking only donor money. If it is like that, it's not going to work. Resilience is not going to happen. So inclusion of to the national and the subnational budget. This is just a sample outline. I'm not going to read this. To help you, you can adapt to your context, but the outline can look like, for example, just this is a sample. We need to have the executive summary with the problem, with the major activity, and then key health priority, and then the resource we need. How we are going to cover those resources. It's external, internal. So then we need to have the introduction. So in the situational analysis, the climate trend, the health vulnerability assessment, we need to summarize what we have done, maybe like 40-page or 45-page. But in this HNAP, we need to summarize that in 2-3 pages to give hint why we are developing. Then the policy and the institutional context has need to have its chapter. Then we need to have the vision, goal, and the objective. And then the vision, for example, we need to align with the health vision, health sector vision, but it's a climate resilient health system that protect all people from climate-related health risks. What are the goals? We have already said this one: strengthen health system resilience, reduce climate-related disease burden, enhance community preparedness. In terms of objective, to ensure this goal, we need to improve the surveillance and early warning, climate-proof health infrastructure, build the health workforce capacity. So, for example, this is the sample adaptation option. This need to come from the VA report. But the early warning, the infrastructure, the WASH, the disease control, the emergency preparedness, health workforce, community engagement, research these are a very important priority, need to come in the VA as an adaptation option. So these are the area for the health sectors, just to give you an end. Then we have to have the implementation framework with leading the key partner, what they can contribute. Their role also need to be very clear in the HNAP, the financing strategy, the funding source, as said, the monitoring and the evaluation with the key indicators, the data system, how we are, for example, DHIS to the health information management system. And then the other is what are the learning mechanisms, the review meeting, feedback, and then adaptive planning. So we need to identify the risk. Once we develop it, what are the risks? how we are going to manage the risk, the policy integration as it's integrating to the health, to the wider development sectors. Then sustainability, there is a need to institutionalization of the HNAP to the Ministry of Health system. Again, the district, the healthcare facility, and the province has local ownership is very important. We need to attach a summary of the VA to this HNAP, stakeholders consultation report, technical guidelines, and the tools how we are going to implement. So in a nutshell, WHO developed in 2021 a 6 criteria to check the quality of the HNAP. The first one is the leadership and the enabling environment, which we have already said. The second one is cross-sectoral coordination and the policy coherence, comprehensive coverage of climate-sensitive health risk in that country or local context, comprehensive coverage of adaptation option, which I've already mentioned some of them. It's not only that one. And then resourcing. This is one of the criteria. Number 6 is monitoring, evaluation, and the reporting. These are the basic 6 criteria to evaluate how the HNRP is really aligned and address the health risk, and then also making sure the health system is resilient to respond to this risk. And then better off the reducing the mortality and the morbidity. Based on this one, I tried to look at the Ethiopian National Adaptation Plan, which is from 2024 to 2028, against these 6 criteria. If you look at, and you go online in the Google, you will get this Ethiopian HNAP. The strength is Ethiopian HNAP 2 is, which is 24 to 28, is a comprehensive in scope, aligned with the climate health risk and the UNFCCC obligations. It emphasized also the climate resilient WASH and the surveillance system, which we have picked also as a sample. The weakness is financing and the monitoring remain vague. Risking implementation gaps. Cross-sectoral coordination is aspirational, but underdeveloped. The priority, for example, in the next time when Ethiopia is going to review after 2 years, the priority action is to institutionalize the leadership, secure domestic financing, expand coverage to neglected health risks, and establish measuring, monitoring, and framework. Like the neglected health risk was the occupational risk from climate change, the heat stress is not well addressed there. If you look at also against these 6 criteria for Uganda's HNAP, the strength is Uganda HNAP is well grounded in national climate policy framework and address major climate-sensitive health risks like malaria, cholera, and Ebola. The weakness is financing and the monitoring framework are vague, risking sustainability, mental health, nutrition, and occupational health were overlooked, was not considered. These are the major impacted by the climate variability and also climate change. So the priority action, for example, when Uganda is going to review the HNAP, they need to institutionalize the leadership at subnational level, secure domestic financing, expand coverage to neglected health risks, which has been mentioned above, and also establish measurable monitoring framework. There was no framework in that. So as the takeaway, what are the expected outcome? The expected outcome from the HNRP is building climate resilience system and reduce morbidity and the mortality associated with climate change. So to ensure this one, there is a need, as I've clearly mentioned in the presentation, governance and the institutional instruction, ownership, climate health committee. We need health in intersectoral ministerial climate change committees. We need a norm and the legislation as a part of the health norm and the legislation. The planning component to ensure this one, which I have already said, health national determinant contribution, where we need to report. We need to have the health vulnerability in the adaptation assessment, the health national adaptation plan, which I've already said, and also the national and the regional plans. The health infrastructure and the service is very important, the carbon emission, environmental sustainability, sustainable procurement, climate resilient adaptation measures is very important. Then the health and the climate surveillance, climate sensitive disease research and the surveillance. We need to integrate a database. We need to have the observatory. For example, we have observatory in Mozambique and Ethiopia where they are picking the environmental variables as well as the climate information. So we need to have the early warning system, which is going to be covered next week. So the health co-benefit from implementing these, what are the health co-benefit from the other sectors when they are doing even mitigation on the air quality and also on the others. Then the research and the capacity building, we need to promote it. We need to have training materials, health professional training, and interstructural collaboration. For example, on the research and the capacity building, Mozambique has developed on climate change and the health research thematic area for 10 years. They annexed it to the health research agenda. They have already have an health research agenda. It was lacking environmental health and climate. It was developed and they annexed it to the health research agenda. So this is very important also we need to have. The health financing, as I said, this is the framework I have adopted from one of the colleagues, from the PAO colleagues. So this is very important tool. Then the last one is the last slide, which I want to present is we need to go online, look at this, the health. We need to have the health building block, the leadership and the governance, health workforce, health information system, essential medical products and the technology, service delivery, and the financing. If you look at here, we have a 10 component in this WHO operational framework. For example, under the air information system, we have assessment of the climate and health risks and the greenhouse gas emission. We have the integrated risk monitoring, the early warning here, and then the health and the research here. Then we have the climate resilient and the low carbon infrastructure and technology and the supply chain. Then the management of environmental determinant like nutrition, wash, air quality, and all those. Climate informed health program like the maternal and the child health program. All program we have the disease prevention and the control, both communicable and the non-communicable disease we need to look at because climate change is contributing to those things. So the health emergency. This is very critical for Africa here because according to WHO report of 2022, 56% of the health emergency in Africa is because of the climate change or climate related. So if we don't include the integrate climate to the health emergency response, preparedness, response, and the recovery in Africa, we are not going to achieve even the health emergency response. So it's going to be, if we don't address the climate, because it is contributed, 56% is contributed by climate change. If we don't consider the climate resilience here, it's going to be a firefighting. Whenever fire is occurring, then the firefighters, they go, it's going to be like that. So really, the HNAP is finally is an instrumental in ensuring health system capacity and the resilience to climate change related shocks and the stress and the possible pathway from collapse to transformation. This is the final thing. You will see the health system capacity, the health system resilience here. We have here low. This is a below average, acceptable, and then normal. When there is a shock, it's going to deviate from the normal. Then it comes to collapse level if there is no adaptation capacity for Africa. Again, if the capacity is to somehow in place, they can recover, but it's not returned to the normal level. Then if we have more capacity, then it goes to recovery to pre-existing status, if it is okay. Then, since we know the shock, we need to make sure we can go beyond the normal because now the climate change is making abnormal. So we need to increase the adaptive capacity, recover better than before. Then finally, the ultimate goal of the Health National Adaptation Plan is when the shock happens to keep to the next shock, so ensure that it withstand, and then the health system is resilient. All the service is continued at healthcare facility and at a community level. I took these two snapshot from the health operational framework. You can go and see online. I've already put it in the footnote. So finally, I've tried to look at also, I would like to tell you also, you can be assisted if you are trained on AI with a repeatable AI system that is supported by organization. You can assist it with the AI to develop your vulnerability assessment and also to develop your HNAPs. I look at it how using the AIA, WHO is paying for it. There is a platform for that. I look at how what I have been presented is addressed the objective. You can see the adaptation option is only 95%. The other is 100% on average. This presentation addressed 99% of the training objective. Thank you very much. It is very quick, and I hope you can go online. And then in most of the slide, you will see in the footnote the reference, and go and read those reference. I didn't create it by my own alone. I just went to the existing document from what I have presented over the last 15 years, and then the current update based on the WHO and the UNFCCC. I've tried to prepare this presentation. I thank you all for listening and for participating in this workshop. I hope it will help you, if not 100%, to some extent, it can help you some way for you to start and to take courage and then produce your own vulnerability assessment and the prioritize adaptation option. And then once you have done that, and go to the developing health national adaptation plan, and then implement and monitor and then revise it. Thank you.
Thank you. Thank you very much, Professor Wataji. And that was a very insightful presentation indeed. And thank you so much for showing us how the different policies communicate from the National Adaptation Plan, Health National Adaptation Plan, as well as like some of the key stakeholders, that are involved in the process. And I particularly liked how you mentioned the role of universities, because I think in a lot of our African countries, universities usually play a periphery role when they're actually supposed to be actively involved in making sure that even our policies are informed by research, and also the research that is done by universities is responsive to what is come up, the needs of our community. So we're really grateful for that. Just a reminder to everyone that the resources will be shared on the WhatsApp group and on different platforms, so I encourage you to join. Then please share your questions on the question and answer box. If you put your questions on the chat, we will likely miss them. So please share your questions on the question and answer. So without wasting a lot of time, I'd like to welcome our next speaker, who's Dr. Kodu. Before I welcome Dr. Kodu, I would also want to remind people that we have English, French, and Portuguese interpretation. So please choose your preferred language. So I encourage you not to just leave the session with original audio. Choose interpretation, so that you'll be able to listen to speakers who will also be speaking in different languages as well. And also we also encourage our speakers and myself and everyone to also speak slowly, so that the interpreters will be able to interpret as well. So I'd like to welcome Dr. Kodu Badin, who's from Senegal, the Minister of Health and Public Hygiene. As a specialist in health and environment, and works at the Directorate General of Health as Health and Environment Focal Point and National Focal Point for the Alliance for Transformative Action on Climate and Health. She coordinates the multi-sectoral working group on health, environment, the analysis process of health system and communities, vulnerabilities of the of as well as the development of the health national plan adaptation to climate change. Then she's a member of the Health Climate Committee and participates on behalf of the Minister of Health in heat wave early warning. She works with national, international organizations and partners for collaboration and partnership to address challenges to combat the adverse health effects of climate change and health. And I think from a biography, you're already seeing multiple stakeholders coming to play. You're already seeing an example of different partners and of actually of leadership that is involved in in collaboration as well as governance and coordination of responses. So we're really excited to also have more people present some of the practical examples in terms of health national adaptation plan is also some of the processes that have been involved. So over to you, Dr. Kudo, and thank you so much for making time to join us.
Thank you so much, modérateur. Bonjour tout le monde, je vais m'exprimer en français. Je vais essayer de parler.
So I will speak French, and I'm so sorry. And I will try to speak slowly to allow the translators to send the message. So let me share my screen.
Donc, je suis Dr. Kokou du Sénégal. Je vais vous partager.
So I come from Senegal, and today I'll share with you this experience from Senegal in the case of the process of the National Adaptation Plan for the healthcare sector. So in this context of the climate changes. In our agenda, we'll discuss the context and the issues related to climate and healthcare in Senegal. We'll also discuss the national institutional policies for climate changes, discussing the key points of it and the results obtained, and the challenges for the establishment of this national plan and its perspective. So here I will present you to Senegal. That is a country that has more than 700 kilometers of coast, and this geographic element justifies this strong vulnerability of Senegal in terms of the climate challenges, because we've faced mainly heat waves that are stronger and stronger and more frequent. So temperatures are rising. And we also have problems with the lower variability of the intensity of rains. And as I said, it's a coast country. We also have the floods, mainly in the area of Dakar and the big cities, and we also face problems with the drought. These vulnerabilities are also present in the context of the increased vectorial diseases transmission, and also the effects of the climate changes in agriculture leading to food insecurity, mainly in the case of children, and the high heat. The alternated high heat brings thermic stress with impact to the cardiovascular health and respiratory diseases. We also have traumas with a physical and psychiatric shocks due to the climate changes and infrastructures that are destroyed due to this variation that disturbs the continuity of healthcare services and access to water, which also contributes to the increased vulnerability and the guarantee of the base services in Senegal. In this case, for us to talk about the institutional and political scenario, the climate change today is a concern in the government reform for the long-term agenda, aiming at changing the structures, considering the elements of vulnerability as key elements in terms of healthcare. We have two ministries piloting that. The first one is the Ministry of Health, and then the National Committee of Climate Changes that is nationally contributing to that.
La première édition est en 2020 et actuellement nous avons la deuxième version. C'est des
And it was defined in 2020 with elements validated in somehow a different way. We started establishing this P&A process, and I'll go back to this point, but we also have the integration of climate in the budget definition. So we have the annual budget law that is a green budget policy.
Du Haut Conseil de sécurité sanitaire, nous avons la coordination One Health.
And we also have the Board of Sanitation with the One Health coordination with a technical group of climate changes. So we have thematic groups on climate change. And we have a leadership in the Ministry of Health where we have working groups that are multi-sectorial related to the environment. And we've also established a technical committee that is multi-sectoral. So this joint ministerial segments and authorities, and even the National Assembly, also with the participation of research and training institutes and organizations of the civil society, communities and partners for the development of this collectivity, make this comprehensive group of players involved in this debate. To discuss the key steps of developing this national plan of adaptation for healthcare, it is important to say that the country benefited from a funding that was the PNFM project that was developed for the discussion of environment as well as to prepare the adaptation in Senegal, which has gone through the National Adaptation Plan with the key elements for the country. So in fact, it started by reinforcing the national capacities, but mainly with the policies for the existing budget. And in the case of this project, we lost her audio for a second. So we also had a vulnerability analysis for the issues of climate change, which leads us to the first step of this process. That is to assess the vulnerability, starting with the diagnosis of vulnerability by region with a cross-analysis of epidemiological and climate analysis and mapping the risk zones with many zones. And we also aim to do that in the field. So here we have cartographies presenting the survey and as well as identifying the regions that are more vulnerable to those climate changes. We also identify the adaptation capacities with a sensitivity data so that we could develop this general index. Regarding the methodology, in the case of vulnerability, we used a mixed basis with Alifante, and we had quantitative surveys and also participative ateliers with a variety of players as healthcare agents, communities, and decentralized services of the state, and focal groups with the key informants that were the teenagers and women that brought important information to the adaptation strategy. The main results were that we had an important vulnerability of communities and a big influence in the healthcare system due to the climate changes. We lost her audio again. I guess she's having connection issues.
Hi, Dr. Kudu. We can hear you. Maybe you can turn off your camera so we can have a better connection. Thank you.
Allô, désolé, je crois qu'il y avait une coupure, une coupure.
Yeah, we lost your presentation. You can share again, and maybe you can turn off your camera
Ok,
so
c'est
you can
ok.
have. Okay, thank
Ok.
you.
Ok. Euh, Aidez-moi à couper la caméra, arrêtez la vidéo. Ok. Alors, cette analyse
Okay, I'll
aussi
turn
a
off
permis
my camera and
de
go
mettre
on.
en lumière que les stratégies
So here,
actuelles sont inaptes pour renforcer la résilience des systèmes de santé. Et à la clé de cette analyse, donc, nous avons
an
identifié des
important
options
point to
d'adaptation
identify because the
préconisées, mais
current
inspirées par les
adaptation
impacts
strategies are
sanitaires
not
réels. Donc,
okay
des
to
options d'adaptation qui
reinforce
sont ressorties
the
même
elements of
des communautés.
strategies
Des défis ont été
impacted by
identifiés
the
aussi. Ces
sanitation
défis sont basés sur
problems
une analyse
lived by
sobre
the
le cadre d'OMS, du plan
communities.
d'action de
The
la santé, mais aussi des
challenges
cadres de
identified
la Convention
came from
internationale
a
de solutions
SWOT
de la climate.
analysis and the
Et ça a mis en place donc des
WHO
défis liés aux
assessment
ressources
and
humaines,
the climate
aux
action plan
inégalités d'accès
of
aux soins,
health in
à
Belém.
la faiblesse des systèmes de
So
données
we can
en
start with
santé, au
lack
manque
of
de
human
financement et de
resources,
priorisation,
inequalities in access
mais aussi à
to
une
care,
insuffisance dans la
and the
sensibilisation.
weak
Donc,
data
faible
systems,
conscience des liens
the
entre climat
lack
et santé
of fundings for
santé stratégique
prioritization,
communautaire.
and lack of
Alors, pour l'étape 2, c'est
sensitivity as well.
l'identification donc et la
That is
priorisation
very
des options
important for the
d'adaptation. Nous
community
avons utilisé
strategy.
donc une
The
méthodologie
second
basée
step
sur la
is
gravité,
to
l'urgence, la
identify
faisabilité et le
and
coût-bénéfice
prioritize
dans
adaptation
une approche
options.
multi-acteurs,
So here we based on
prenant
elements
en
of
compte des questions de genre et d'équité, mais
feasibility
aussi
and
en
benefit,
définissant les priorités
considering the
nationales
players
sur certaines
as
maladies.
well as elements
Et
of
les options
equity
retenues
and
donc,
national
au
priorities of
terme
some
de cette
diseases as
identification
well.
sont la
And the
nécessité de
options
renforcer la résilience
that
du
we
système
had
de santé,
were
de renforcer les systèmes de
strengthening
surveillance, d'alerte
resilience
précoce
of
et de
healthcare
riposte contre
systems
les
with
maladies
the
sensibles
sanitary
au
risks
climat,
related to
de
climate changes,
faire la promotion
reinforcing
de la recherche
systems of
transdisciplinaire et
observation
l'intégration
and
des dimensions
early response and
innovantes en
reaction
matière de climat
of
santé, de
diseases
renforcer
sensitive to
l'engagement
climates with
communautaire,
a
la
huge
sensibilisation et
potential
le
for
plaidoyer en
epidemic,
faveur des questions
and to
climat
promote
santé et de renforcer les
interdisciplinary
capacités
research
de
and
gouvernance, de
integrate
planification et de
innovative
mobilisation des
technologies
ressources.
for healthcare and
Euh, toujours
healthcare
donc
systems,
pour la
among others.
planification stratégique et la budgétisation du PNA qui a
So
été
in
l'étape suivante.
terms of the
La méthodologie était
strategic
basée sur des
planification
directives, les
and
bonnes
elements
pratiques, des
of
exemples
budget
et
for this
expériences au
plan,
niveau
here the
national,
methodology was
régional et
based
international,
on
et
the
des premiers
benefits,
récents et
best
les plus
practice,
pertinents en
examples,
matière
and
d'adaptation.
experience at national and
Donc, ça s'est fait
international
suivant
levels,
une approche
the most
participative
pertinent for
organisée et
the system.
concertée pour la rédaction du
And
document. Donc,
it
tout
became a participative approach that was inclusive and organized to develop a document. Everybody was invited to participate. We defined a strategic framework with a budget for the activities. We also identified the feasible projects to be submitted to climate funds and the development of a plan and also the return and follow-up of data. Well, some best practices to be mentioned, first of all, consider the climate changes in the new public healthcare policies. So these are policies also related to a new strategy of changing the healthcare systems. And we also have catalytic funds like the Climat Santé. In terms of governance, we have coordinations of observations with the national committee being established with a multi-sectorial and regional elements to establish a pilot element. And we also have an early warning system established for some years. And currently, we are also developing an action plan for warnings in healthcare with this collaboration with the research institute to develop protocols in climate and health. And we currently work with other adaptation projects that can have fundings, and we submit a proposal to the Global Fund. Here I show how we established this national plan because it requires leadership and engagement at high level, efforts of the intersectoral coordination, reinforcement of the institutional capacities for the sanitary risk related to climate, and to collect data related to healthcare, and to reinforce the local adaptation and community engagement strategies, and engage in the mechanisms among others. And the perspectives to follow the implementation involve the identification of process impacts and results indicators, and indicators for the ones chosen, integration of indicators in the healthcare system. And here the information is also due to demands of the system of follow-up and periodic assessment, and the use of data to readjust the strategic and operational interventions. So to conclude, and we lost connection again. So the adaptation is imperative to prevent and fight against the elements that we are facing. The Senegal plan is a good idea of a participative and multi-sectorial approach with a strong engagement, but the success of the plan depends on the availability and the sustainability of funding and political engagement, but it can be an example of integration between climate and health in the west of Africa. This plan was not politically validated yet. It's important to mention that. So it will be analyzed by the respective ministries. So with that, thank you very much for your attention.
All right. Thank you. Thank you so much, Dr. Kudu, for that. And I think I'm seeing there have been a lot of questions around governance, around coordination. I think you did very well in giving a practical example in terms of how you've approached it in Senegal, and particularly how it's also rooted in evidence, particularly when you looked at how different regions, even within the same country, who have different vulnerabilities. As well as, I think for me, what I also found impressive is how you also tried to align it to existing policies and frameworks, and also utilize existing sources of data as well. Like not really starting completely new, but really looking the importance of leadership and multi-stakeholder coordination, as well as utilizing existing resources. So thank you so much for this. Just a reminder, I noticed there were a lot of questions around interpretation. So I've just put up this slide to show you how to activate interpretation. So this is for audio interpretation. So we have English, we have French, and we have Portuguese. So please choose the language that you prefer. And as you know, our continent has many different languages. So this is an off effort for us to learn from each other across regions. So really, I applaud the organizers for this deliberate effort. And there have been questions around translation of slides. This is for audio only. For translation of slides, I encourage you to. There's so many tools you can use online for free to translate slides. So thank you so much. Now, I'd like to introduce Mr. Lolem Lokile Bosco, who's a public health leader and scientist with over 20 years experience of practice in environmental health. He holds a master's in international public health and a bachelor's in environmental health, plus advanced certifications in pesticide and chemical risk management, climate and health and diplomacy, health impact assessments, environment impact assessment and audit, monitoring evaluation, corporate governance, and strategic leadership. He's an assistant director of public health and currently serves as the Kenya Ministry of Health as the head of the unit on pollution control, waste management and climate change and health, and the deputy head of the Division of Environmental Health and Sanitation, among other responsibilities. Internationally, he coaches the WHO-led Friends of Clean Air for Health on behalf of Kenya and is the Kenya's focal person for global framework on chemicals and One Health and Beyond. He coordinates and supports the development of various policy, regulatory, strategic documents, as well as publishing the space of air pollution, clean energy, climate change, health, and chemical safety. So really, as you see, we really have impressive leaderships on the continent as well as experience on the continent, and we're really grateful, Mr. Lolem Bosco, for taking time to really share with us your experience and expertise. Over to you. Thank you.
Thank you, Tinashe, and my pleasure to also be part of this session. And I want to go to my slide and is it okay? Sorry, something happened. I think there. Yes, just a little bit. I want to remove my video. I hope it's fine now. Yeah, yeah. Okay, yeah. Thank you very much, and really appreciate the opportunity to share our Kenyan experiences. And for this, I would want to also note we are in the process, and you'll appreciate also that in the presentation, I'll be giving a bit of context in regard to just climate
Dr.
change.
Nolan, it's not in presentation mode. Can you put in presentation mode, please?
It's not.
No, it's
Okay,
just
sorry.
the PowerPoint.
Okay. Thank you. Let me just go back. It goes this way. Is that fine? Is it fine now? Is it okay?
No, you stop sharing now. You need to share again and put in presentation.
Okay, yes.
Perfect. Thank you.
Okay. Thank you. Sorry. Yes, so I'll be quickly be taking you through a bit of context in regard to introduction, especially from the perspective of health or climate change, and some of our processes. And you will appreciate how we kind of hybrid, not just about health adaptation, but we are very strong in terms of mixing the adaptation and mitigation processes as part of our strategic efforts to address health impacts of climate change. And I'll be keen to kind of also give you a bit of our strategic framework and some of our one key particular aspect that we are happy to also share with you is our implementation vehicle, which we are calling the Kenya Green Health Platform, and some of the challenges, lessons, and just summarize the key takeaways. So, for Kenya, and that is Kenya on the western shores of the Indian Ocean, which is located in East Africa, and appreciating from the Copenhagen map, you will find that Kenya has a mix of climate. Only the polar climate may not be available in Kenya, but it's really diverse. And from our public health risk profile of 2023, appreciating that also significant public health challenges, diseases, conditions are also climate sensitive. And I am going to show you a bit of just some perspective on the significance of the vector-borne diseases in the Kenyan households. And we recently checked in our Kenya Health Information System, the DHIS2, the data for 2021, 2026, and we're checking on around three vector-borne diseases. And you can appreciate that this climate-driven conditions is both large and geographically concentrated. And you realize even malaria, like places in northern western Kenya, like Turkana alone, accounted for up to 60% most of the diseases, and the distribution consistent with the relationship between temperature, precipitation, and the vector, Anopheles mosquito. So also, like for the visceral leishmaniasis, at least we can maybe follow on the Kalahazar, which is transmitted by sandflies. The habitat requirements are also tightly coupled to vegetation cover and soil moisture, nearly double between 2021 and 2025, from around 3,000 to around 6,000 in annual cases, which was up to close to 96% increase and represented just not more than 1% of the total vector-borne diseases burden across the period. And like other counties, those are our sub-regional levels, West Pokot, Turkana, and Wajir together accounted for close to 65% of all cases. While one that is also kind of very minor had a rise of 470% in a single year between 2021 and 2022. And that was just from a few hundred to over 2,000 cases, which was a spike far larger than its aggregate shares and a clear signal of acute epidemic risk. So I just wanted to show you within the track of the 9 WHO quotations that are followed in the Health National Adaptation Planning, how significant the vector-borne disease in Kenya is. And this also just a photo of some of the recent weather events, and this was landslides in our part of Kenya. And Kenya, the Great Rift Valley runs just directly through Kenya, and we had this in a place called Marakwet East, and we had serious landslides that killed close to around 40 people just to us last year, in November 2025. Again, you can appreciate to us around 2023, just the photo on your left is a health facility that was submerged in water in our lake region, that's Western Kenya in Kisumu County. And again, you realize even on your right the impacts that droughts sometimes also have on our population. You can see pastoralists trying to make a cow stand, but is already extremely emaciated. So it's not just but about saying, but we are in real circumstances, and you follow even right from 2023, 2024, 2025, and early 2026 in March, we have had serious flooding in Kenya. And for the policy context, Kenya, like other countries who prescribe to the UN Framework on Climate Change Conventions, has a suite of policies that speaks to meeting or complying to some of these commitments, right? Even from the World Health Assembly Resolution on Climate and Health. At UNGA, we are currently even putting our country position on the pandemic preparedness and climate resilience that is coming next. We also are keen, especially you realize even our recent NDC is really heavy on health adaptation. And but over and above, our key driver, just like many of the countries that have signed to the COP26 commitment, is ensuring that we undertake the vulnerability and adaptation assessment and develop a costed health national adaptation plan, in line with also committing to kind of also drawing into the commitment on climate change and health under COP29. And so, out of and also coming from COP26, Kenya took a bit of a different path. We thought and we figured that we need a framework, a policy framework, not just going direct to vulnerability and adaptation assessment. And so I think we are among the few countries that decided to develop a climate and health strategy whose goal is to achieve low carbon climate resilient health system by 2029. And within it is there are 7 priority areas, right from promotion of health, energy transition, and improving air quality to enhancing climate and health resilience research, policy integration, partnership, resource mobilization, monitoring, evaluation, and learning. And so, key here is to ensure that we meet our strategic direction of ensuring the health sector is low carbon, is also adaptive and climate resilience, and has the necessary leadership to coordinate and ensure the implementation of this framework. And so within the Kenya climate change and health strategy, this is where we realize that we really need to move in speed, and we are doing simultaneously a number of deliverables. One is on development of the Kenya Climate Health Vulnerability and Adaptation Assessment, which is now completed, and that is what we are calling the phase 1. Yeah, because it's clear that sorry. It's clear that from the context, it brings about the diversity in terms of climate extremes. And so this V&A maps current and future climate health risks using the IPCC framework in regard to exposure, sensitivity, adaptive capacity, and via a composite climate change vulnerability index, which runs from 0 to 1. And the findings are also paired with another innovative approach that we have also kind of come up with. It's still under development. We are calling the Kenya Climate Health Resilience Intelligence System, KCRIS. This is an interactive digital climate health platform that would help us visualize vulnerability indicators, disease trends, and county level evidence. We have 47 counties in Kenya that are more of semi-autonomous governments. And so we really want to give them the necessary instruments to ensure the integration of climate and health within the sector. So, in regard to key climate trends and disease burden, these were also just clear, and you can see from the chart on the front, and particular attention goes to the vector-borne diseases that is really increasing. But from our graph, the intelligence system, this shows total climate-sensitive cases climbing from 2016, which were 2.8 million in terms of climate-sensitive cases, to 5.5 million in 2025 nationally. And so climate health risk will continue to intensify through 2050 without targeted adaptation and financing in Kenya. And so but what next for us? We just want to show you that we are in the process, and we are currently we've been developing a set of two. I'll be giving you a set of two guidelines that we also kind of want to really go into the mitigation, especially that, and also the adaptation from a different approach in terms of operational level, and also continue the framework as guided by WHO. And so we are currently at procurement stage to complete now our CHBA. In that process, would we having a timeline of up to February 2026. And so as soon as we advance the CHBA and ensure the operationalization of the electronic climate health vulnerability and adaptation, or the KCRIS, we intend to now start the development of the costed health national adaptation plan, which will help us anchor our Kenya's response and unlock the national climate finance as well as support development of county-based costed climate health adaptation plan. We really are looking forward to each county to adapt the health national adaptation plan to its planning process, because in our counties are usually doing what we call the county integrated development plan. And for the sector, we need also a county-owned health adaptation plan. And so these are going to be provided in terms of the important foundation, the county health data profiles that are also come together under the phase 2 of our climate health vulnerability adaptation assessment. And so that is that for this. And we also intend to have what we are calling the climate health investment case. And we are interested here in malaria, TB, and HIV/AIDS. And this also part of aligning with our current global fund cycle. And we hope to have also a targeted adaptation investment, especially for hotspots within the sector. Then we intend through the ECHBA to strengthen the disease surveillance, also guide in monitoring, also and development of heat health action plan, and also integrate the health information system with climate and health. And under this, we are going to transition our manual reporting of environmental health and climate health events or indicators or targets within the ECHBA and under another system that the ECHBA will be feeding to. We are calling the Environmental Health Information System, EVIS. And this would really help us in terms of mobilizing resources, and also help us in the county level model disease projection for all the 9 climate sensitive categories. And so at the end, we will be having our CCBHI across all the and across all the 47 counties. So I was talking about our hybrid approach. This is a system mitigation level guidelines. We are calling the Kenya Green Health Guidelines. This is providing guidance on how to address 9 pillars within the mitigation space on health. And these are also requirements that was put in the Kenya Climate and Health Strategy, right from leadership and governance, energy, waste, food services, transportation, digital health, green procurement, supply chain management, and green building and infrastructure management. You realize the mix between adaptation and mitigation here. And so again, under this, we have a clear pathway on how do we really make this happen, right? From initiating action, identifying people, earmarks funds, building plans, celebrating in terms of sharing results, recognizing teams, scaling success. Then we evaluate, pick some of the best prior projects in terms of high impacts and identify partners as well as start again. So that is that for the Kenya Green Health Guidelines. Then we have also just completed development of the guidelines for what we're calling the climate resilient operation, improvement and construction of health facilities. And in our unique approach as a country, you realize that if we were to really go through the V&A and develop the HNAP, this particular guidelines is speaking directly to HNAP. And as it is speaking from the lens of our strategy, we decided to have it developed, and probably after development of the HNAP is when we will work through to update it to be in line with the HNAP. But over and above, this is our more of adaptation level and climate resilient guidelines that is speaking from an operational point, health facilities. Checking on health facilities, and you realize on how do we, it has 4 sections, but looking at section 2 on step-by-step process for climate resilient health facilities, you realize that we are introducing facility level vulnerability and adaptation assessment, and we intend to have this like twice every year in each of the facilities. We have over close to 17,000 health facilities in Kenya, but looking at the mid-level to higher level health facilities, these are where we would want to really follow up, and we have all the tools within the guidelines that we are going to be piloting in some of the counties. So that is for the guidelines for climate resilient operations, improvement and construction of health facilities in Kenya. Then over and above, within the approach on V&A, HNAP, the Green Health Guidelines, the Climate Resilient Guidelines, we have established the Kenya Green Health Platform, which has 7 work packages under one system. You realize it as operationalization of the platform, the workforce capacity, evidence and the monitoring and evaluations, piloting of the green hostels, no partnership, advocacy and policy, finance and mobilization of the same. So this platform is still in its very early setup, but you can as well also appreciate, especially organizations and also individuals who would wish to work with us, because each package has been developed in detail with sub-activities and connect to each of the others so that it accelerates the others and also ensures a monitoring approach, ensures an appreciation on the way. And so this is just but about how to kind of integrate mitigation and adaptation into the health system. So for other perspectives and other efforts, we've developed a lot in terms of the air quality. We have a very good coordinations, knowledge sharing and early warning. We are the first country to and the founder member of the Pan-African Environment, Climate Change and Health Network, and happy that we have Senegal here who will be hosting the second Pan-African Conference on Climate and Health in 2027, and looking forward to really work through and also continue working together. And we've faced a number of challenges as well as a number of lessons, right from the data gaps and weak research linkages, constrained financial capacity to facilitate technical and policy formulations and strategies, limited technical capacity, infrastructure, the aspects of determinants relating to social and environment, public awareness, the gaps in policy and implementation, the issues of institutions, and also changing partner landscape in terms of funding. And all this has also given us a number of lessons, right from the country roadmap, sustaining country approaches, leadership support and commitment, coordination mechanism with committed partners, and trace has been really good. And so just but over and above, and just the key takeaways, I don't want to also go through each one of these, is Kenya has comprehensive climate change policies and strategy aligned to its global commitment and is working to integrate this global commitment in local action to build a low carbon and adaptive health systems. And so from our phase 1 of our CHBA, and our plan is also anchored on ensuring that be complete as per WHO requirements, our CHBA and our HNAP by June 2027. And this would be still within the time frame that has been given based on the commitment that countries should develop the V&A and then HNAP by 2030. And so over and above, the Kenya Green Health Platforms act as a centralized collaborative coordination mechanism that synchronizes actions across government, ministries, NGO, academia, and the private sector. And so this institutionalized climate and health that we are putting together would help us put together the voluntary system in regard to the partners, stakeholders who are keen, interested in being part of the process, as well as also will give us opportunity to really work through and see who are not yet in, and yet they are significant or critical in the process within the industry or the sector. So I want to end there because of time and really appreciate the opportunity that I've been given and Kenya Minister of Health has been given. Thank you.
Yeah. Thank you so much. Thank you so much for really showing, I think, some of the practical ways in which Kenya is approaching synchronizing and multiple sector collaboration, as well as creating platforms that facilitate that and also exchange of data from county level to national level. This is good practical work. I'm noticing time. We apologize that we are above time, but so maybe we can just take time for one quick question for each speaker, and then I think the rest of the some of the questions have already been answered via chat, and some of the responses will also be shared during the resources. So maybe for each speaker to Prof. Kutane, there's a question on in like from based on your experience, how can we ensure that climate health adaptation plans identified through the V&A assessments are integrated into routine health system planning and budgeting rather than remaining standalone donor-supported projects. So really looking at the vulnerability and adaptation assessments and how they can be integrated into routine health systems. That's your question. Then maybe I can also give Dr. Kodu your question so that you also work on your responses. Dr. Kutane is responding. To Dr. Kodu, there's a question on how you can explain more in terms of how One Health coordination works in technical working groups. I think there have been structures that have been mentioned, um, different structures in terms of climate change and health frameworks and technical working groups. So the question is around how One Health also coordination comes in. I think there was also another question as well, even directed to the other speakers around really how where One Health is positioned in all of this as far as coordination is concerned. Then, Mr. Lodem, there's a question on nutrition. If there is like there's a question that talked about how the nutrition component is missing, and if there's hope for inclusion of that, and noting how the different areas are affected. Then maybe tying to that, you can also maybe share more information as well in terms of where people can find some of these platforms that you mentioned and how they can find information as well. Since we also understand the limitation of time that you may not have presented everything in depth as well. Yeah, so over to you, Dr. Kutane, then Dr. Kodu, and Mr. Lolam. Thank you.
Yeah, thank you very much. I'm not going to take time a lot because the time is here is almost dark. So for me, I've almost answered a lot of questions since I stopped. I was just responding, including the One Health and all those things which came to address to me. The HNAP, if you remember my presentation, the last two slides, I put it the health building blocks. And then also I put it the health system resilience, how the show come, they collapse and then transform it. So for me, from the experience, most of these things, when you do the vulnerability assessment, the adaptation option is going to be identified in the vulnerability. It is not in the HNAP. It's already ready. So the expert, the group, they are going to use it. So when we are planning, we need to look at within the framework of the health building block and then the 10 component of the WHO operational framework. One of the colleagues asked me, are we going to consider all the 10 components? No, it depends on the local context. Even those 10 components in one of the options, if you identify them as a priority, it is not going to be implemented throughout the country because the vulnerability mainly is depend on the agroecological zone. If you remember, my colleagues, Professor Balai, have presented that. So it depends on the agroecological. So disease normally follow the agroecological zone. So it's even in one country, one option is not going to be throughout the country. Then the financing issue, we need to think of how, for example, look at the government is building with a capital budget a new health infrastructure. They are doing renovation. Just this is one example. They have for new healthcare facility infrastructure building. They have for renovation funding. Now, what the climate component is going to do, depending on that agroecological zone, what are the building code? Because the country has their own building code for hospital, for healthcare facility, and for health center and the clinic. So now the issue is how that country is going to develop a standard infrastructure that can be resilient to a given agroecological zone. So what they are going to do is to develop the code, to revise the code, to the building code to address the resilience. So we are thinking, because there is a misunderstanding, I'm sorry to say, in climate change, in all sectors, when we are thinking climate change, we are thinking the Western money. I'm always saying in training, if we are expecting to ensure the resilience, only the Western money, the developed countries support the donors, we are not going to achieve. So we need to include that in the building code. For example, one of the example, we here in Ethiopia, we used to have a project. Then we developed a training manual, and then we in collaboration with Addis Ababa University. At the end, Addis Ababa University approved that 15 credit hour for in-service training, a module. So now the project is not there. This module is serving in Addis Ababa University as additional course, a module. So when we are having a module, a project, we need to leverage that, how we are going to integrate to the existing system. Now that manual is available, they are using for training. So we need to be strategically think of how we are going, this is integrating to what? To the health workforce, because it is already there. So the HNAP need to be developed by taking into account the national health budget or the national health financing system. But we need catalytic funding to incorporate to the existing part, like what I said on the health workforce. For example, we brought the EWARS, we are implementing the EWARS in 15, like 20 sentinel sites, but we used the existing surveillance system. Now, the arbovirus sentinel site came, they used for arbovirus, because the arbovirus is now using what has been already established. The government is using that, what has been established with the climate funding when we used to have. But over the last 4 years, we don't have in Ethiopia that funding, but the work is ongoing. So we need to be very strategical when we are developing HNAP. And then, as I said, using the universities I mentioned in my presentation, it helps us working with them to integrate to the existing public health course of even at master's level, and then at the undergraduate, it is part of the education system. So these are how we need to integrate when we are thinking of adaptation option. Thank you.
Thank you, and you can go ahead, Dr. Kudu and Dr. Leonard, and I think if you can make your responses brief, that would be great. Thank you so much.
I think, do I go?
Yes, you can go ahead, then Dr. Kudu can come up to you.
Thank you, thank you, thank you. I think I've answered a number of them, and however, the question on nutrition, and also cholera is what is missing. And let me appreciate Rachel Dungo for the question on nutrition and also the statistics that she's given. You realize from the Kenya Climate and Health Strategy, we have a food system as priority two. And so we have just established a technical working group on climate and nutrition. And this, we've had already 3 meetings, and we will be keen to have a framework on climate and nutrition. And those are already systems that are clearly in place, other than probably not really giving a mention in terms of within my presentation. It's keenly taken into account in terms of, and they are running it a bit of semi-autonomous from our unit. Then on cholera, the mention of TB, HIV, and malaria, just for the sake of starting, but over and above, these are within the 9 WHO disease conditions of concern. And so this is critical. And even with the El Nino rains, we have a multi-agency team that is already in place working. We are currently undertaking assessment on our readiness and preparedness. And so that is not, that it has not been taken into account. Yeah, thank you.
Yeah, thank you. And Dr. Kudu?
Oui, merci beaucoup. Donc, j'ai été interpellée
Thank you for the
sur la
question.
question de la coordination One Health.
Someone asked me about the One Health
Le
coordination,
Sénégal a mis en place donc
but
un
just
programme
to
national de sécurité
emphasize,
sanitaire
Senegal has
qui est
implemented a
déjà en
national
primature
program
sur décret
of
donc
sanitary security.
mis en place par décret au niveau de la primature, que ce programme national est mis en
It was made by
par le
decree.
Haut Conseil national de sécurité sanitaire One Health, qui a mis en place une task
So
force
the High
multisectorielle au niveau
National
de la primature.
Board
Donc, il y a
of
toute une équipe qui est dédiée à
Sanitation
ça, qui est bougée
decided
au niveau
that,
de
and
la
we had the
primature et qui recrute l'ensemble des
sectorial
grands intervenants
task force. So we
santé
have a
animale,
whole team
humaine et
dedicated to that, and we
environnementale.
have a set
Et
of
donc, il y a
people,
des groupes thématiques,
not only
donc
for
en
human
fonction
issues, but also for environmental ones.
sensibilités des différents secteurs. Et parmi ces groupes thématiques, il y a un groupe sur la biodiversité
And
et
the
le
goal,
changement
among
climatique.
others, is to
Donc, il est
touch
de 7
many other
questions
sectors
et avec qui donc,
regarding
nous travaillons, qui
biodiversity,
travaille beaucoup
climate
avec le
changes,
ministère de la Santé dans le
and
domaine du
approach
changement
these
climatique, mais
issues.
aussi avec
So this
les autres
work is
partenaires.
carried out closely
La
with
deuxième
the
question, c'est par rapport
Ministry
au
of
processus
Health as
du
well as
PNA.
other
Quelqu'un a demandé
stakeholders.
combien de temps ça a pris. Juste dire que ça nous a pris 8 ans.
Regarding the
Nous avons
process
commencé depuis
and the plan preparation,
2020 avec le projet PNA fin. Nous avons
we
mené
started
une
in
première phase d'étude donc, de
2020
vulnérabilité
with the vulnerability project, and then we carried out the studies
PNA santé. Ensuite, ces études de
and
vulnérabilité ont été
developed, in
reprises
fact, a first
approfondies
draft.
de façon très
And then we
détaillée et
followed,
différenciée.
after the
Et ça nous
vulnerability
a
studies,
permis donc de
we
remettre
got
à jour nos
deeper in a
documents,
very
de l'aligner avec
diversified way,
les
which
priorités
allowed us to
gouvernementales, avec des
update the
nouvelles
document
recommandations, engagements au
and
niveau
align it with the
international
governmental
pour
priorities and
renforcer
the
le
new
document. Et actuellement, nous sommes à la phase finale.
recommendations and
Nous avons
international
budgétisé, nous
engagement
avons
to reinforce the document.
stabilisé
And
le
now
document
we are in
et donc
the
bientôt
final
nous allons
phase,
procéder à sa validation politique.
and the document is now being established with these political elements. That's it. Thank you.
All right. Thank you so much, Dr. Kodu, and thank you everyone for making time to attend the session. So just a reminder to join the WhatsApp group and also look out for email for the resources. So the next session next week We'll focus on early warning systems and surveillance. That will be on Thursday, 3 September. So we encourage you to attend. And just a quick reminder that the certificates will only be given to people who attend at least 8 live sessions. So you have to attend live sessions, at least 8 live sessions, and also get at least 70% in the assessment. More information will follow. So thank you so much, Messi. Asante sana, asante sana, obrigado. Have a lovely day, everyone.
Bye.